Thank you all for joining us today. We are going to be talking about home health care options. I am joined by Jamie Vella and Stephanie Owens. Jamie is with Capital City Nurses and Stephanie Owens is with Amedisys. Ladies, thank you so much for being here today.
Thank you for having us.
Thank you, Debbie.
I know there's often some confusion about the differences in services that you both provide and also and how you work together. And that's what we're going to be talking about today to make it hopefully clear things up for folks who are looking for care. They may know what they need and not know what's out there. They may not know exactly who they need, and we have you to tell us about that. Stephanie, will you please share with us about the medical services that you offer through Amedisys?
Yes, we offer skilled nursing services by a registered nurse, physical therapy, occupational therapy, speech therapy, a home health aide, a social worker, and a dietitian.
Wow. Okay. A variety of expertise. And Jamie, you offer some different kinds of services.
Yes. So with in-home care, it's a little bit different than the skilled services in that we're providing primarily non-medical services. So they're mostly provided by, there's so many different terms for what in-home care, what the caregivers are. So it could be a private duty aide, it could be a home health aide. So we can just call them, caregivers, if you will. But so they're providing more of the activities of daily living. So it's more of the helping with bathing, dressing, things that require like hands-on care, like incontinence care, maybe helps with physical assist with transfers. But then we're also helping with other things that are not hands-on, like light housekeeping, companionship. We're able to offer medication reminders. We can't do like the skilled nursing services that Stephanie and Amedisys do because they're doing more teaching. We can actually just give medication reminders. So that can be helpful for compliance. And then also things like errand running and helping a client get to an appointment. So we really focus on those non-medical activities and things that seniors need help with in the home.
Okay, so two very distinct services. So Jamie, what does someone need to do? What are the requirements to obtain your services?
So to obtain non-medical care, it's really simple. Really, anybody can obtain it at any time. You don't need a physician's order for it. It really can come down to just whether someone's needing some help in the home. So usually a friend or a family or a physician might recommend that they need in-home care, but it really just takes a phone call or putting someone in touch with an agency to or someone like myself as a home care specialist to kind of just review those services. And it's very easy to get care started. Sometimes it does take like a catastrophic event or a medical setback for someone to really understand, like, I might need in-home care, and it might come from an agency like Stephanie's, or also a hospital or a rehab center that someone's actually understanding that they can use our services or need our services.
Okay, so more on our own, more independently searching out for you. Okay, Stephanie, what about with Amedisys? What are the requirements for obtaining care from a nursing services provider or medical services provider?
Medical skilled services.
Medical skilled services.
So kind of piggybacking off of Jamie, normally we require a change of condition or some change of medical status. With ours, you do require a physician's order, and I can talk a little bit further about how that transition goes. There are certain requirements that your insurance requests because insurance does cover our skilled services. Depending upon what insurance you have, it varies to how much you would pay out of pocket, or if your insurance pays 100%. If you are a Medicare Part A primary care participant, then home care is covered at 100%. If you have different insurances, they do cover that. It's just different ranges of how much they cover in order for those services. So ours mainly starts with a physician, either in the hospital, in a physician's office, in a rehab, ER, anything like that, that kind of sees that they need a little bit of extra physical care for the insurance to cover it out in the community.
Okay. So Jamie, what about home healthcare, home assistance care services that you all provide? What is the pay situation for that fees required covered?
Sure. Well, it's quite different than than the skilled medical services. Currently, third-party payers and payer sources like Medicare don't cover our in-home care because it's considered not medical. So that would, most of our clients are private pay. So usually it's out of pocket. We have hourly rates, for our clients, but there are a few things that do cover in-home care. One is if someone qualifies for veteran benefits, that is one way that a certain amount of care can be covered. The other is through Medicaid. For instance, my sister in Virginia, she's disabled. She has 40 hours of care under Medicaid services. Not every agency does take Medicaid. Like just for an example, with Capital City Nurses in Virginia, and a lot of areas of Virginia, we do take Medicaid, which is where my sister lives. And then in other agencies do not accept Medicaid. So in Maryland, we do not work with them. The other thing is a lot of people, folks do have long-term care insurance. A lot of people bought policies years and years ago, and they've been paying a hefty premium on those policies. That long-term care insurance, if a client meets criteria, can actually have services paid for. There are a few little nuances that go along with the long-term care policy, and no two policies are the same. There's usually a period of time they do have to pay out of pocket before their benefits kick in. And when they do, there's a daily allowance. So a lot of families just sort of plan that out ahead of time. A lot of agencies, including ourselves, help our clients sort of navigate that process and make sure that we get documentation to their insurance policies, just to kind of have that easy button. But those are the ways that our services are paid for.
Okay, great. You mentioned when you were just speaking now about daily allotment, daily allowance. It makes me think about this amount of services that a client can receive from your company. What does that look like? What is the range of times
Sure.
and hours?
It can range completely across the gamut. We have clients that use 24/7 care, so that's around the clock care, and then there's also services that are just a minimum. We have a minimum of 4 hours. Now, some agencies do a little less, so it can be up to a few hours all the way to comprehensive care. It really depends, and with agencies, it can be very flexible too. You might start off with a lot of care initially, such as coming out of the hospital, when you might have skilled services like a medicist. A lot of times people will also bring in our care at that time. But then as things improve and as conditions stabilize, we can always decrease care. So it can start high, it can go lower. And then sometimes it starts off really light and then it can go higher as well. So it is nice to know the beauty of in-home care is that schedules can be very flexible.
Very personalized. There's not like you said, there's not a one size fits all, and you're not confined into one schedule. You have that flexibility. Exactly. So with Stephanie, with the occupational therapy PT, what are the frequencies and days for you?
That is all determined by the clinicians or the therapists that go out to do the initial visit. On average, it's about 30 minutes to 60 minutes a day. Up to a certain amount of days per week that the insurance allots based off of what specifically is going on with the patient. Patients who need a higher level of care, such as like Jamie talked about, our goal is to get the patient as independent as possible. So that's how we kind of work with some of the, private duty agencies like Jamie's to kind of reiterate some of those exercises and stuff like that so that the patient can become as independent as possible and remain in their home. So that's our goal.
Okay, terrific. So we talked a little bit, get some input from doctors, some from rehab, but referrals, I would imagine, are a large source of your work as well. I mean, they come through the doctor's office perhaps, but where do you find referrals come from? Either of you. Stephanie.
Yeah, I'll go. A lot of ours are hospitalizations or rehabs. So a lot of times we'll have a patient that will have a fall or something out in the community, go to the hospital, then go to like a short-term rehab to get some 5 days a week therapy, and then they discharge home, which is a great transition. So I kind of helped transition them home and continue that therapy in their home setting versus in the rehab.
Okay, great. And Jamie, what about you? Where do you find your referrals come from most of the time or often?
Yeah, kind of a mix. It could be, again, skilled agencies like Amedisys. It could come from a hospital social worker that knows it's not going to be safe for someone who's living alone to, discharge, home by themselves. Perhaps families working and they can't be there at certain times. It could come again from that transition from a rehab facility home, a direct referral from a physician's office. We work a lot with geriatric care managers, who are really very heavily involved in the care and needs of their clients. And at times it can just be families and friends who know that you're a resource in the community. So it could be a friend of a friend that might reach out. And again, it's kind of that word of mouth sort of reputation. And so it really can come from anywhere.
It could even come from Winter Grace Senior Ministries.
Exactly.
Yes.
Oh,
Certainly
whatever. So that's word of mouth and Winter Grace and all of those other things.
For sure.
So what would you just want to kind of go back a little bit back to the beginning about services, because in just like this few minutes we've covered so much information. Again, what do you see as the differences in your services? Like, what are the main differences? We talked a little bit about duration, payment, services, and what anything you'd like to highlight to go over again?
I think our services are more to be considered short-term. We want to work really aggressively right at the beginning to try to rehab those patients in their home. We do have patients on services for a longer amount of time, depending on what needs they have. But our goal is to teach and then pass on that to make the patient successful without us in the home. So that's kind of why the insurance covers more our services, because it's that that medical follow-up initially, and then our goal is to teach the patient or the family, whoever the caregiver is, and any other caregivers that are in there to be able to take care of them when we're not there.
Okay. Thank
I
you.
think that definitely is a difference. Yeah, it's more short term, and with in-home care, it can be very long term, and we can really like pick up and carry out, when their services are complete, and kind of continue that patient making progress, not with the medical oversight, but, a lot of times their therapists go out there and they make great programs for them, for their patients, and they need a little more time, maybe not progressing quite as, fast, but, having a caregiver, private caregiver in there can really help, keep things going along until they're more safe and even more independent. So, but yeah, you kind of hit the highlights as far as like our payment sources are different, medical versus non-medical. I know that, Stephanie, one thing we might want to highlight is, I know the home health aid. I mean, you do have some home health aid services, and and just the difference in sort of the duration of that aid. A lot of people kind of think like, oh, an aid is covered by Medicare. But just that it's a very short-term, situation, very short visits, and not everybody qualifies for that, right? Right, Stephanie?
Correct. So what we consider a home health aide or a caregiver is very short-term. There are different requirements that need to be met in regards to a skilled nursing, a nursing oversight needs to occur, occupational therapy, which kind of works on showering, bathing, dressing, that sort of thing has to be involved at the time of the home health aid visit. So it's very short, very 30-minute, help you to get in and out of the shower, give you some tricks of the trade, and then we leave. Whereas your services are more, more personalized and condensed and longer throughout that day.
Right. We can come in more frequently, more, more hours that they might need. And some other needs obviously can go along with just that bathing visit. So that is probably a pretty big difference. But, again, it's nice to have options of having, both of us, and sometimes both of us in there is really like the best scenario as far
Mhm.
as giving the patient everything that they need. Obviously, there's some budget and things that need to be taken into consideration, but in an ideal world, yes.
I
They'd
can
be
also see
together.
there are definitely situations where you transition from one to the other and back and forth, and you two, your companies and the two of you work together to, I'm sure you two work together to help coordinate care, like, I don't know, I don't know, passing off isn't the right word. Sharing services of each other so the clients that you're working with have the best of both worlds, but best of what they need.
Absolutely. So I think there's been instances, and Jamie, you can speak of it too, where we've gone out to do our, initial medical assessment, and then we find that the patient just needs a little bit more care than what they have available in the home. And that's when, we can reach out, get confirmation from the family or the patient that they're okay with us reaching out to an agency, such as Capital City, to see if they can assist with some hours when we're not there. And then we found that sometimes, as Jamie said, they'll graduate from our services, and then they're working with them for a little bit, and then they see maybe they're not doing the exercises as well, or they're a little bit weaker. And then Jamie can always call and say, hey, this patient, you had her before. She's not doing the exercises or well, or she's having difficulty, can you check with the doctor and see if we can get an order for you to come back in? So we kind of worked back and forth with that. Yes.
For sure. Yeah.
Wow,
And
that's terrific.
it's always good sometimes when, people are coming out of the hospital and they're sick, to just having those extra eyes, because Skilled's in there working as hard as they can, but only for, again, a finite period of time. And if someone's at risk to go back for the hospital, it's nice to have, extra eyes of a caregiver sometimes there with them, help with that medication compliance, and just, the really goal is to keep them safe at home and out of the hospital, which is, not only is it expensive, but it's more taxing on the health system. So working together is definitely a good plan. And also, we have clients at home that have been with us sometimes for years, and we want to keep them home and strong. So in home care, there's reassessments that happen in regular intervals, and there's nurses that are overseeing our caregivers. So it is nice too. Those nurses are always looking to identify if there's been a decline or a setback, something that maybe they've fallen and not hurt themselves enough to have a fracture and end up in the hospital. But we really try to have those early eyes to see when that decline's happening, and we'll reach out to Stephanie and really find out, can we get an order? Has there been enough change where we can get this covered for them? Because again, both of our goals are, keeping people at home as safe as possible. So
that's great. And so if I come home, or my parent comes home from the hospital, we have your services, and then there's situations where those insurance payments run out, but the person's living alone and still needs services. So is that a time where you all kind of work together, or what are some things that maybe are suggestions that can be done for that situation?
Yeah, I know with our skilled services, when we re-review the goals and the plan of care every 3 weeks or so. The therapists do with the patient, the family, and if they're meeting those goals, then we can continue to ask insurance to pay for our services. But we really do try to keep communication wide open with everyone to know, kind of what the plan is, and if we have to change some goals, if somebody's having a harder time adjusting to something that we thought initially they'd be able to do, then we readjust the goals, and then we do a different plan of care. So we're constantly kind of working with that. But there is definitely weeks notice and more than that for when we're thinking that the patients kind of maximize that potential. And then we'll absolutely reach out to other agencies to see about, helping with those services when we're out.
Excellent. It's just such a difficult time, as not being able to be the person who does the caregiving, or not having the skills to care for your loved one. It's so good to know that there are agencies and business resources for us to be in touch with and help care for our loved ones. So what are some takeaways, final takeaways, that you would want everyone listening to remember?
Jamie, you want me to go first?
Sure, you can go first.
Okay. I mean, the biggest takeaway is that our goal is to keep you at home, keep you out of the hospital, keep you safe. And there are so many tools out there that seniors aren't aware of. And we kind of want to be the resource, both of us be the resource. If we can't help you, we'll find somebody who can. And we just want to be available to not only teach the patient how to properly take care of themselves and but also be a support system for the families that are working full time and having to do all this on their own. So our goal is to make every transition as seamless as possible.
Fantastic.
Absolutely. Great takeaways. To piggyback, off what she said, obviously we have very similar goals for our patients and clients. Is really just just being fully aware to know that in-home care and skilled home health, just that our services are there. At some point in the life of a senior, you're going to encounter one of us or both, but just knowing ahead of time, just to prevent that reactive state of we're in a crisis and now we have to get all these services in place, is just really going through your resource fair, which is amazing, and just really understanding in-home care, skilled care, so you can be proactive about it and advocate for yourself. So I think that's a good takeaway as well.
Oh, that's terrific. Yeah, both Capital City nurses and emetocysts are part of our resource fair, of course. And one of the things that I love is knowing the two of you and having met other people in this caregiving world, that yes, we want to give the best representation of what each service provides. But I know if I call Jamie and what I'm talking about is beyond this, is a different scope of services, that you can refer Stephanie and vice versa. And that communication is always open, and you'll have a network of care services that you can share, even if you're not the right one. And that's just very reassuring. But hopefully people can review this and learn some of the differences and feel a little bit more confident in reaching out too. So
that's good. Thank you so much for all that you do with the Winter Grace Fair. It really is wonderful.
Oh my goodness, thank you. I appreciate you both
Debbie.
being with us today. And as I said, the information for connecting with both of these ladies is available right with this video, and we look forward to seeing you at the fair. Thank you so much.